In South Africa, the risk of a healthcare associated infection and then the risk of that being a multi-drug resistant infection is too high. And it's important for us to actually be doing something about that because it can only get worse if we don't.
Welcome back to the WSPID podcast series, brought to you by the World Society for Pediatric Infectious Diseases and the WSPID Antimicrobial Resistance Committee. Hello, my name is Penelope Bryant, and I'm the co-chair of the WSPID AMR Committee. I'm a pediatric infectious diseases physician working at the Royal Children's Hospital in Melbourne and researching at the Murdoch Children's Research Institute and University of Melbourne. I have great clinical and research interest in everything we can do to improve the use of antibiotics in children. I'm your host for this part of a two-part special looking at global success stories in neonatal and pediatric antimicrobial stewardship. This episode, we're focusing on stories from Africa. Before I introduce my guest, I'd like to remind you to check out the global e-learning portal on the WSPID website for access to resources on AMS. Now, antimicrobial stewardship is a critical component of high-quality healthcare and a key determinant of patient outcomes. To shed some light on the clinical experience in South Africa, I am joined by Dr. Dena van den Bergh. Dr. van den Bergh is an award-winning healthcare change leader and leadership mentor for healthcare and health tech professionals. Based in South Africa, with a career spanning over 30 years, Dena is a global leader in antimicrobial stewardship research and large-scale change projects. With a doctorate in engineering and a background in pharmacy, Dena has developed a unique approach to healthcare change, which she has used to implement multi-hospital AMS initiatives across both public and private sectors in South Africa. Welcome to the podcast, Dena.
Oh, thank you. It's lovely to be here, Penelope.
Well, thank you very much for taking the time to join me today. You're so accomplished in your professional life. I wonder if I could start by asking you to tell us something about yourself that perhaps your work colleagues might not know about you.
Yeah, well, thank you, Penelope. I was racking my brain thinking, those of us that work in healthcare, we tend to sort of do so much of I certainly have fun in my work, but I had to find something outside of that. And I came up with, I realized I've done 600 game drives in national parks in South Africa. So I'm wearing my leopard today just to celebrate that. And yeah, but I think a lot of my colleagues will know because I'm a real advocate for having ways to restore and recover. And for me, nature and being out in nature is one of those. So yeah.
That is a fun fact. All right, so I'd like to just to start really broadly and ask if you could briefly describe your involvement in neonatal antimicrobial stewardship.
As you said in the introduction, I mean, my world is really about health systems strengthening and health systems improvement and change. And in 2012, I was a co-founder of the South African Antibiotic Stewardship Program. And along the way, we realized that there was work we needed to do in neonatal. We've done quite a bit of work in the adult world. And so we initiated some work through the South African Antibiotic Stewardship Program in neonatal studies. So I'll tell you more about the one initiative, which was a public-private sector neonatal study. And at the moment, we managed to get some funding to continue that work in two of our hospitals here in Cape Town. And we're specifically looking at sustainability of that program. You tend to do these studies, but really what I'm interested in is how does a health system adapt and continue that work after the study period is done.
And so, what would you say is the real the sort of raison d'etre for antimicrobial stewardship in children? Why is it particularly important in neonates and children, do you think?
Well, we all know how vulnerable neonates and children are, and especially in the neonates, which is where I've done most of my work. In South Africa, the risk of a healthcare associated infection and then the risk of that being a multi-drug resistant infection is too high. And, it's important for us to actually be doing something about that because it can only get worse if we don't. And so, we take it very seriously. We also have other issues in systems, shortage of staff, overcrowding, and those kinds of challenges, resource limits. make the risks even higher. So yeah.
And so I think that leads very nicely and directly onto understanding the risks is then what can we do about it? So can you share a standout AMS initiative from your region and specifically involving you that significantly improved care in neonates or children?
Yeah, so when we sort of woke up to the fact that we really have to do something in the space of neonatal stewardship in particular, South Africa, you often get these headlines in the newspaper about babies that die or the mortality rate, and those are, they always remind us of like how important this work is, but they also speak to what the system actually looks like, both across the public and the private sector, and so we decided we wanted to start doing this work, but the truth is we don't have ID trained pharmacists in neonatal stewardship. We don't have a lot of infectious disease specialists um, across the country, and so we had to think about ways of doing that that are specific to our circumstances and our that fit our resources. So we do, as we typically do with this kind of work, we did a call to action, and we brought together some of the senior, researchers in this field to help us actually design a study. And we put together 7 private hospitals, 7 public sector hospitals, and we'd done a friend of mine that I collaborate with in the United States had done some work on culture negative sepsis. And so we thought, well, maybe see what's going on, like what's happening with culture negative sepsis in South Africa. But we also knew that there was very little, there were pods of activity happening in different, mainly academic centers, and that had never been brought together as a movement, as a change that we were going to try and bring across multi hospitals in South Africa. So that study, we focused on culture negative sepsis, but we were also looking at what are the other issues that come up around antibiotic usage in neonatal units. And we particularly put together a multidisciplinary team. We realized we're going to have to use pharmacists that do not have this specialized knowledge. If we pair them up with neonatal infectious disease practitioners or pediatricians, and then we added clinical microbiologists, some of who were remote and not on site, and also neonatal nurses. So that was the study design across those 7 hospitals. And I can say more about that if you.
I definitely want to know more about that. So, Dina, what were the specific challenges that you faced in implementation and how did your team overcome them?
Yeah, so what was great about this work is we actually started by asking the people that had responded to the call to action, what are the barriers and enablers of neonatal stewardship in your unit? We also did a situational analysis. We asked them, what do you already do? Like what's happening? And out of that work, we really had sort of 3 key issues. The first one was time. Like we don't have time. The second one was really issues around knowledge. We we were a bit afraid of this work. I'm not sure that I want to be making recommendations about things I'm not really familiar with all of the nuances for neonates. And then the third one was really relationships, the sort of going bringing the multidisciplinary team together and and building those relationships so that they could actually work together and support this work. Um, yeah, those were the key things, and we wanted to know those up front, but also solve for them. We can lament them, and we can complain, and we can do all of those things, but at the end of the day, the question was, so how are we going to do this work if that's a reality? And so we did what we call countermeasures. We designed the work to try and alleviate some of those resource constraints and some of those barriers. And the first thing we did is we call it allocated time. So we had very specific interventions, very specific. We don't want you to go there and spend hours and hours and hours looking for all sorts of different things. We want you to understand which of the neonates are culture negative, and which ones are on antibiotics. And so we did this thing called allocated time. You have 1 hour every day, 5 days a week, to go and do these specific things, and we provided training about those. And we also put together the multidisciplinary team. So we solve time by doing allocated time. We solve knowledge by some upfront training, plus connecting you to people who know more, which is the microbiologist, the pediatrician, and the neonatal nurses. So we also helped with time because we brought in nurses who could point things out easily and quickly, and they're there all the time. And so once they were orientated as to what to look for, they could point out to other members of the team, this baby's been on antibiotics for 3 days, or this baby. So we, those were some of the ways in which we solved some of those problems. We designed it that way, and then we played it out, and we had a way of recording. So what does it actually help? Does it solve the problem, or do you still have issues? And we tracked that throughout the study. So we did the clinical measures, but we also got feedback, narrative from the people that were involved. And we had what we call feedback sessions, learning and feedback sessions, in which the teams would come back and say what's happening. And we also had them sending us some of their stories, which was very, very informative. And then we reflected at the end of that study. We did exit interviews with the different professionals in the group, and they shared with us like what some of their learnings were, and also what they would do going forward.
That's very interesting because I'm particularly interested in the time aspect because we all, in every setting, have problems with time. And I thought you were about to answer that you had caused a rip in the space-time continuum and somehow solved it that way. But I'm interested just to delve a little bit into what you mean by allocated time. Does that mean you were sort of streamlining it by allocating it, or how did that actually work?
So the main people that were collecting our data and doing the interventions were the pharmacists, and they are stuck in the pharmacy mostly here. So we know that they can't just leave the pharmacy and do the work they do in the wards only either. So um, when we approach each hospital, it's like we need you to allocate 1 hour a day for one pharmacist to visit the neonatal unit and have this interaction with the team. And then most of them set up WhatsApp groups as well, because so that conversation could continue throughout the day. And then we also figured out what they could do while they were in the pharmacy when the scripts were coming to the pharmacy. And so that allocated time was getting management permission for a pharmacist to do this 1 hour every day, 5 days a week. And that's worked very well for us in previous studies with adults. So we wanted to see how it would work with neonates. Um, and it really did make a difference. It's never perfect. You don't kind of get it
Sure.
every day. You have, so there are things that go wrong. And we also hit COVID um, in that work. You
What?
know, well, yeah, we did. And amazingly, we didn't abandon the study. We kept going through that whole process. Yeah.
That's fantastic. I think it's of interest that obviously you were doing this across multiple different institutions. So I'm interested to know whether you found that there were differences in like cultural differences, institutional
Mm,
resource-based differences between the institutions
absolutely.
that you had to tailor your interventions towards.
We definitely did. So obviously in the academic settings, there are more infectious disease people around. Um, they had less microbiologists on site. Um, and so that was also interesting, figuring out, most microbiology services are like a phone in, but then only the person you phone has that information until the documents arrive in the ward as such. But we found that the way in which the microbiologists could communicate across the public and the private sector had to be dealt with, and they figured it out. So we didn't have to we could share ideas, but they actually figured out, now that they have a person and they want to solve the problem, they figured out how to communicate and who needs to know what and how they could make that happen in their setting. Also, in the private sector, the doctors are not employed by the hospital. And so there's a lot more work that needs to happen up front around communicating and around their participation. So we also had to share information. We invited them to some of our learning sessions. Um, so we had those kinds of differences um, that we had to work through in all the different settings. I'm a system specialist, so like we always say you cannot change a system until you can see it. And so the thing that happens when we bring them together and we start sharing information, they start seeing, oh, this is what we're doing, and this is what we could be doing. And you open up the possibilities of solving the problem because you start speaking about it and you start looking. But maybe we could do this and maybe we could do that. And we got them to record anything that they did together that was changing the system um, and improving how they work together.
Yeah, so interested in the private partnerships that you had, and particularly how you both got private practitioners to see the problem and see that antimicrobial stewardship really does underpin everything that they do, but also how you incentivized or persuaded them to participate.
The first thing that's so important about private sector is because each doctor is independent. Every pediatrician, every neonatologist works on their own. They never see collective data. So one of the ways in which we use is to share data. These are the number of babies that have a healthcare associated infection. These are the multi-drug resistant patterns. So when you're treating one baby at a time then you're not always seeing the whole picture. And just sharing a set of data that is our data becomes collective rather than being accusatory, rather than being about your patterns. That data becomes something we can influence together, and that's part of our process. I don't think there's any doctor in the public or private sector that can't see the impact that antibiotic resistance is having and isn't worried and hasn't faced a set of lab results that go R, 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 R. So, I'm a big believer in just ask for help. Like, would you be prepared to work with us so that we could solve this problem, so that we could improve the system? And I have never had um, a private sector or a public sector doctor say no when you share data and you ask for help. Because it's one thing to police a system, and it's another thing to co-create a better system.
Yeah.
And that's the ethos that we try and bring to this work. And I think it's made a big difference in how many people are stepping forward and wanting to be part of the process. People are really interested in being part of a study and seeing their names um, at the end of a publication. So that's made a huge difference. In We had 89 health professionals in that study.
That's amazing. Because I was going to actually ask you next what lessons you would sort of give to somebody trying to start this from scratch, but I think you've sort of partly answered that in your last question. But any other thoughts, in addition to what you've just said to, if you're starting out?
Yeah, I would say, don't be a lone wolf, like find a partner, find like even one partner makes this journey easier. Because when, I mean, I'm very passionate also about collective stewardship. So, so that like having 14 hospitals tackle culture negative sepsis actually causes a change across all 14 hospitals in exactly the same time period. Having one hospital do it and then another one say, oh, maybe we should have a look. And then another one saying, and what about, and others saying, I don't think it's a problem here until you look. Um, so for me, we've done several multi-hospital studies, and just finding one other study, one other site, or one other person who's willing to go on this journey with you can really make a difference for the down days and the days where everything goes wrong. And when people are saying no, when you want them to say yes immediately, it makes a difference.
It definitely does. So I mean, you've worked in lots of different settings. Have you seen any low cost or scalable interventions, or introduced low cost or scalable interventions that could work in even less resourced environments than you've worked in?
For me, the very first piece of work that I did, we called the low hanging fruit. And we it started off, I went to a webinar. It wasn't a webinar then, it was an in-person lecture at one of the universities about antimicrobial resistance. And I was sitting there thinking, like, what are we supposed to do? I mean, I've been hearing this narrative about the big problem, but there was very few people saying we need to do something about this. The call for action and the specificity of it is important. And so we sat down, myself and a microbiologist called Adrian Brink. He's done a lot of work here in South Africa. And we wrote down the 6 things we think we could improve that we know are happening because we work in these hospitals. Um, and like, let's go and see whether we could do something about them. The first one was cultures prior to commencing antibiotics. Now, that's not possible across all of Africa because of some of the challenges around that. But there is work now happening around, what do you do? What's the low hanging fruit, or the before that even? What are the patterns we could see? And so I think for me, it's like start with like 1 or 2 things, like more than 3 antibiotics being prescribed. Removing, the double cover was was like it it was definitely happening. And then we started sharing and showing data and intervening, having pharmacists say, I see you've prescribed this. And those were all low hanging fruit, small things, and it starts the movement. And then we shared data. So, hang time was the other one that in fact, we did it in South Africa first, time to administration. And then that's been replicated in South America, it's been replicated in Lebanon, it's been replicated. And that one was, how do we administer antibiotics within an hour or 2 hours of prescribing? Now, it's a very we took it even broader. Of course, the data is only really about sepsis and how important, but we actually took it seriously across any time it becomes necessary to prescribe an antibiotic. We shouldn't be waiting a day, you know, uh, 10 hours before you actually administer it. It should be administered. So that started an awareness. We measured how often, what timing is the current system producing? And then we started saying, so what can we do to bring that into either the 1 or 2 hour process? And that very system that had nurses talking to doctors, talking to pharmacists, started to create a change in the system. What antibiotics do we have in the ward? What, when, how does when the doctor writes the prescription, what's the process that happens straight after that? How does that get to pharmacy? How does it, all of those things we sorted out and showed an amazing improvement. And more important than that, it started the relationships. It started okay, well, we've done this. What else could we do together? And then we could find specific, the next thing. And so I'm a big believer in choosing one thing at a time or a little bundle of related things and do those.
Oh, that's great. Thank you. So we'll just shift gears slightly, and I want to talk about sustainability of antimicrobial stewardship in organizations because it is a challenge. And I know you speak so passionately about how important it is to use organizational change principles in AMS programs. And I wondered if you could say a bit more about that and how organizational change principles help tackle the question of sustainability.
So I'll start off with my favorite quote, which is I've already said one of them, which is you can't change a system till you can see it. The other one is every system is designed to give you exactly the results it does. And if you want a different result, you need to have a different system and you need to see which parts of that system actually give you the best results. Because there's so much to change in a system, and it can be very overwhelming to want to do everything. And so the principles of organizational change is choosing and something that makes a big enough difference and doing that one and then using that as a process for you to take that work forward. And I think that that's the basics for me. The second part of organizational change is recognizing that there are hierarchies. There are hierarchies in a system that we need to work with. And so some of us are sort of academic, we might be researchers, and we have this view about management, and we complaining about support, or we complaining about things that need to be done. But honestly, they are part of your system. And so if you do not acknowledge that, you will you will you can do the study, but it may not be sustainable. If I give you allocated time now, and then at the end of the study you go, oh, thank heaven, like come back to the hospital, come back into the pharmacy, that's not a sustainable system.
How have other aspects of stewardship that we think about been involved in organizational change for you? And specifically, I'm thinking about diagnostic stewardship. How has that been integrated into system changes that you've implemented in neonatal stewardship?
In the study we did, as I told you, we did include clinical microbiologists in that work. And sometimes those were on site, but mostly they were not on site. And sometimes the the people, in the hospital had never met them. And so again, I come back to, like, now that I know who you are and I have you on my phone, I, as the pharmacist or the neonatal nurse, can actually have this relationship with you. There always was a relationship with the clinicians because they phone in the results to their clinician. That was a big key. But we also wanted to make sure that everybody else understands some of the basics so that they could be doing things um, when the clinical microbiologist isn't available. And we specifically had learning sessions to inform the multidisciplinary team of some of the key things that were important. So things like how difficult it is to get specimens, how important it is, that process is so important, and making sure everybody understands the risk of contamination. Um, those were some of the things we did, but we also, in a previous study with adults, we got some of the other members of the team to recognize some of the diagnostic stewardship elements and make an intervention around those. And, those are also possibilities.
And so, sort of overall, from your favorite program or your biggest program. How have your strategies impacted clinical outcomes, which is really what we're all after? Did you see any changes in resistance patterns or reductions in hospital length of stay or mortality?
We definitely saw reductions in length of stay. We didn't do big enough numbers to show a change in mortality, um, but we showed no change in mortality for the numbers that we had. And, because of course that's a big fear. Are you gonna not give antibiotics now and then, that causes a death? So we didn't show any change in mortality, but we did show both a decrease in length of stay and a decrease in the length of treatment or length of antibiotic use. And that's important in neonates, and it's important in adults too. The longer you are on antibiotics, the more impact, the more risks there are around that. So yeah, I think those were the ones. But I think when I think about it, like the biggest important outcome for me is that health systems recognize the risks of infection and the need to have programs to preserve the effectiveness of antibiotics. And, at the end of the day, we do it for that cohort of patients that you're working with, but you're also impacting the broader system. And, I've made sure that I take these stories to the boardroom and to the places that need to hear them, because they then determine resources going into the future. They determine priorities. And so when our resources are limited, how do you decide what you're still gonna do and what are essential services? So I recently had a manager say, "Oh, we've had staff cuts and we can only do essential services." And I just launched into an immediate response about why antibiotic stewardship is an essential service as it impacts the safety of patients, and that it absolutely needs to remain part of the essential services. And it took a bit of convincing, but
I imagine they were convinced, though, by you.
well, with good data and good stories, and persistence, it doesn't work the first time. I don't want to make out as if every time, you just go, okay, well, there you go, you walk in and you change the system. It's not like that. There are continued hurdles that you have to keep working on, but you cannot lose hope.
With all of your experience, I'd love to get your thoughts on how you might approach tackling a few real world issues through your organizational lens. Are you game for that?
Yeah, let's do that.
Yeah. Okay. So,
Mhm.
so we have evidence from high income settings that early IV to oral switch is safe. How would you approach a culture of excessively long IV antibiotic use on wards in a low income setting, driven by senior medical staff, despite this evidence?
Gosh, we've done some work on IV to oral and not very successful. And the reason that it's not as successful as it could be is it's interesting from an organizational perspective, as you say. So, firstly, in the private sector, moving someone from IV to oral puts a question on whether they still need to be in hospital. And that is already one aspect of it. In other settings, in higher low resource settings, people hold onto the bed, and having someone on IV treatment to keep the bed, so that you choose who comes into this precious free bed, is impacting on IV to oral. I mean, it's so interesting to see that. It's not something many people think about, but you really start to unpack. Like, it's not just you can bring the science and the evidence of why it's safe and why it's good, but actually that's what I mean about having a systems lens. It's like, if you don't solve for, you're going to ask me to discharge my patient, but I don't feel that they are ready to be discharged. There are other factors that I still want them to be here. And then now, if I switch to IV to oral, we've got insurance companies that will phone you and say, in the managed care setting, like, this patient needs to be discharged. We're not going to pay for an extra day. So, that's why. And then I discovered that in non-private settings, in the public sector, the shortage of beds is a real issue, and those things can impact decisions there, and so that's the one aspect of it. But otherwise, the system's the same. You create awareness, you bring data, you use the multidisciplinary team, because we're not always there. And so I'm really a big advocate for more nursing involvement in stewardship. They also have great relationships. Usually, they can they can speak to staff, junior staff, senior staff. They usually have a good relationship with them, and that's how I would start tackling it.
Okay. What about
Mm.
widespread use of broad spectrum antibiotics by junior medical staff, ignoring local guidelines?
That, from a systems perspective, I would say that that has an access element to it. It means they are um, the system is not managing and measuring what you allow and what you don't allow, and that needs us. So, in one of our big units, those medicines are not kept on a ward level, accepting a very limited supply. So you can give the first dose or the first where it's needed, but after that it gets questioned in pharmacy, and it needs extra signature. So people are creating better systems for that. But I think in general, if you ask me, junior staff just simply don't get enough information and training on the importance of antimicrobial stewardship. It's almost like, oh, look, they come and go, and they come and go so quickly that it doesn't feel like you get the opportunity to bring them into the importance of stewardship early enough. And we really need to do more about that in both public and private. We don't have them really in the public sector, because by the time in the private sector, by the time you come into the private sector, you're normally an established specialist, and there's very few junior people there. But you have the same issue. An individual private sector doctor who always prescribes broad spectrum antibiotics. And that for me is a data. I use data to solve that. I show the pattern of usage versus others. We also use the laboratory data. So one of our big low-hanging fruit interventions was drug bug match and de-escalating, which is not an easy intervention, but it needs persistence. It needs persistence, especially when there's like that pattern. Every patient, I put them on a broad spectrum. It can be handled with both data from the peer um, review, sort of a peer comparison, and laboratory data. Everyone knows it's happening, and no one has the conversation.
Yeah, which speaks to what you were talking about right at the beginning
Yeah.
about relationships.
Yes.
And so, what about prescribing antibiotics for infants with probable viral infections in, let's say, community clinics where there's less access to rapid diagnostic tests and greater risk if they miss a bacterial infection than for admitted patients?
In the community settings, the there's certainly in South Africa, the access to antibiotics is not as real as, is not as readily available as it is in the private community setting. So the general practitioner, that work, and we haven't done a lot more enough work on this particular issue, and it's mostly because that data goes everywhere. It ends up so there are now better sources of data to highlight the problem and to bring attention to this. But because our practitioners are all individual private practices all over the country, and there's not a lot of structure around that. The first piece of work that is being, the sort of bringing a structure, bringing data together, and allowing that to then inform the system. And of course, now having more access through online platforms and this kind of work, like podcasts, better communication. I think that's going to raise more awareness around that. Um, and the other aspect that is quite active in South Africa is really insurance, medical insurance companies really advocating for the general practitioner. I think the number, I don't know if it's true that 60 to 70% of antibiotics are actually used in general practice rather than in hospital settings. If that's true, we've got a lot more work to do, and that needs a wider systems approach than in each of us working individually. It needs a so we're going to do some work with that in the South African Antibiotic Stewardship Program, um, by bringing together groups. So I'm back to don't do it alone. You can't tackle it one at a time. You need to create a movement around it and tell those success stories in order for the movement to grow and the processes to unfold as you involve more people.
Okay, and finally, how would you try to maintain consistent stewardship where antibiotic supply chains are inconsistent and shortages are frequent, as in the African setting?
Look, I think for me, those situations are stewardship. The very process of saying, this is out of stock, what else can we use? And how can we use that safely? And how is what the stewards, are doing in that world. They're making some choices. And then the only other thing I can say about that is infection control. Is, if you can prevent the infection in the first place, that can go a long way to alleviate some of the risk factors. But if you, the rest of the process in terms of supply chain, um, at sort of a macro level in Africa, there's more research going on to see what can be done around that issue and how we can we can have alternatives. But and then there's this whole issue of, can you stop manufacturing here? Can we? What are our alternatives around that process?
So, Dina, what's one myth about antimicrobial resistance that you wish we could bust for good?
Yeah, I think it's that it's inevitable. Which at one level we, of course, resistance is a factor, but it's not inevitable that we can't do something about it. And that for me is the issue um, that I think I'd love to bust. And that it means that or that it's like it's somebody else's work to do, but it's actually all of us need to be part of that who can do something about it. And then I think that's the myth that you need infectious disease specialists to do something about that. You actually need everybody that works in the health system to be part of that process.
And just finally, then, if you had to name one key success factor from your work, how would that lead to any final piece of advice for pediatricians building antimicrobial stewardship in their hospitals?
I think my biggest success came from collaborating, but also documenting my work as research. And, I did a lot of work beforehand that helped patients, that helped the system, but I didn't record all my findings and publish them. And I think for me, that is another layer. I think by doing that, we don't only help the people that we serve, but we also help the global system evolve and get better and better. And that's what I would encourage, no matter how small your system, your role is, that there is the possibility to get your data and work with other people and take that work into the health system in general. Go and present it at a conference, as an abstract, or if you can get it published.
Well, that's wonderful. Thank you very much, Dina. I'd like to thank our wonderful guest, Dr. Dena Bergh, very much for persuading us that you can't make change till you can see it, and that if you want an outcome to change, you need to change the system that organizes it. And here's to persistence and building relationships.
Thank you so much. Thanks, Penny.
And that's the end of today's episode. Thank you again to Dena for sharing her experiences of implementing pediatric and neonatal AMS in South Africa. To find further resources and educational content, you can visit the global e-learning portal on the WSPID website, your hub for pediatric infectious diseases insight. Thank you for listening to the WSPID podcast. Make sure you're subscribed on your favourite podcast platform so you don't miss an episode. And please share this podcast with your colleagues. Leave us a review and be sure to tune in next time.